This video is taking you through a series of prioritization questions, similar questions to what you might see on the NCLEX. So prioritization is a huge part of the NCLEX test plan. And one part of prioritization is, do you know who to see first? So these questions are really asking you, do you know expected outcomes? Do you know unexpected outcomes? Do you know your ABCs? And do you know your order of priorities, which the NCLEX really likes Maslow's hierarchy of needs. So let's go through these questions with those facts in mind. We have 4 post-op patients. Who's the highest priority? Someone 4 hours after a hernia repair requesting a snack. I don't think it's going to be A, because it seems like they're feeling pretty good. 4 hours post-op, they're hungry. That's a great sign. We have a client 6 hours after a lap chole with expected shoulder pain. So when you have a laparoscopic surgery in your abdomen, what they actually do is pump your abdomen full of gas so that when they do the laparoscopic surgery, they can see better, they can move the surgical tools around the body easier, and that gas tends to cause a really classic kind of shoulder pain as it's kind of dissolving after the surgery. And our keyword here is also expected. So I don't think that's going to be highest priority. The person's in pain. We do want to look after them, but I don't know if it's highest priority. A client 2 days after a hysterectomy who has not yet had a bowel movement. Well, we probably may want to give this person some bowel care. Understanding that postoperative constipation is kind of an expected outcome. We want to look after it for sure, but I don't know that that's a hugely high priority, especially when I look at D. 1 day total knee replacement, calf tenderness, sudden shortness of breath. So even if you don't know what these signs and symptoms could possibly be indicating, the fact that there's sudden shortness of breath, that leads me to pick this answer. And what it may be happening with this patient is that they have developed a DVT, and that DVT has embolized and it's gone off to the lungs, and that's why they have shortness of breath. So here's somebody's leg, and we have, of course, calf muscles in our legs. And one of the jobs of the calf muscle is to move deoxygenated blood back up to the heart. When you are not moving around because you had surgery, whatever the case might be, you get something called venous stasis. When you have surgery, you also have something called endothelial injury. Your blood vessels are injured, in this case because they got cut open. These 2 factors are 2 out of the 3 factors in Virchow's triad. The 3rd factor is hypercoagulability. And these 3 factors, whether you have 1 or 2 or 3, increase your risk of blood clots. So this person has venous stasis. I know that because they had a TKA, total knee replacement. People don't move very well after a TKA. And because they had surgery, they had endothelial injury. This person has 2 out of the 3 of Virchow's triad. They're at very high risk of a blood clot. So what probably happened is they got a blood clot there, deep veins, but part of it embolized. And embolism is a traveling, in this case, blood clot, and it made its way up to the lungs. So here's the lungs with the bronchi. This blood clot has made its way up to the lungs, and it's occluding the capillaries. So here's my alveoli, right there in blue. My capillaries, whatever's downstream from the clot, is not getting blood through it, or as much as it should. So you actually have a VQ mismatch. So that's why this person has shortness of breath. They may have a pulmonary embolism from a DVT because they had a few of the components of Virchow's triad. So I think D, this person needs to be assessed right away. Okay, we have 4 clients at shift change. Who should we assess first? Chronic pancreatitis, who has epigastric pain after breakfast. Someone who had a thyroidectomy, tingling around the mouth, positive Vostek sign. That's how you pronounce it, Vostek. Someone with cirrhosis, abdomen is distended, more so than yesterday, but they're breathing okay. And a patient with rheumatoid arthritis who wants their next scheduled NSAID. Okay, I'm going to just jump right away to B, the thyroidectomy. So when someone has their thyroid taken out, they are perhaps going to end up with some electrolyte problems. So this person probably has hypocalcemia, decreased level of calcium in the serum. And that can actually progress to seizures. So a big serious problem. And the reason why I'm already suggesting seizures is because of this positive Vostek sign. So that's a really classic sign of what's called neuromuscular excitability. And this is when you tap the facial nerve just in front of the ear, and then you're going to see a twitching of the facial muscle. So you just do a little tap in front of the ear, and then the nose twitches, the lips twitch, the cheeks twitch. And so that tells me this person has neuromuscular excitability. When calcium is low, nerves become hyperexcitable. So just a small stimulus like tapping causes muscle contraction that a small stimulus would not normally cause. So we have neuromuscular excitability. It's probably because of a low calcium, and I know that because of the thyroidectomy. So we are well on our way to this person having possibly a seizure, a spasm of their laryngeal muscles, serious problems. I don't think it's the chronic pancreatitis. 6 out of 10 pain, yes, we do care about, but that's not nearly as close to a risk of seizures. Someone with cirrhosis, abdomen's distended, but they're breathing okay. And our person with rheumatoid arthritis who wants an NSAID, well, yes, that is something we want to intervene in, but B, most definitely highest priority. Okay, now we're in the emergency department. We have a 27-year-old with acute asthma that can only say a few sentences. 44-year-old closed ankle fracture, 9 out of 10 pain. 60-year-old renal colic, 19-year-old fever, and sore throat. Okay, so I'm going to put a arrow beside this 27-year-old who can only speak 1 or 2 words at a time. That's a big problem, not ventilating properly. We are on our way to respiratory failure. We have an airway breathing problem. So definitely we are looking at that one very closely, but let's go through the rest. We have a closed ankle fracture. Well, it's important, but there's no immediate threat to life or organ function or airway. It's a closed ankle fracture. That is a serious problem. And of course, 9 out of 10 is a serious problem, but it doesn't beat out airway. So I'm going to cross out B. So I'm just trying to see if anything's going to beat out A right now. Next up, we have our 60-year-old with renal colic. So here we have our kidneys and we have our ureters going down to our bladder. Renal colic is when we have a stone in a ureter. So the stone formed in the kidney, but now it's traveling down the ureter, and it causes the ureter to spasm as it's trying to push it down. So renal colic means it's coming from the kidneys or in that area of the body. And colicky pain is wave-like pain. So 1 second your pain is 7 out of 10, and then it's 10 out of 10. And then it's 6 out of 10, and then it's 10 out of 10. So classic for renal colic is sudden severe flank pain, pain radiating to the groin or the testicles. And other signs and symptoms are nausea and vomiting and blood in the urine. So someone vomiting with renal colic, we don't want them to be in so much pain that they're vomiting, but it doesn't beat out airway. So I'm going to cross out C. Just anecdotally, I've had patients tell me that renal colic, kidney stones, are the closest comparable experience to childbirth. And this is the woman who told me this was a woman who had unmedicated childbirth, and she said it was the closest experience she's ever had to unmedicated childbirth, so very painful. 19-year-old with a fever and a sore throat requesting a work note. Well, that doesn't beat out airway. So the correct answer is A. Okay, we have 4 clients with GI disorders. Which assessment finding requires immediate follow-up? So we need to look into this more. A person with ulcerative colitis who has tenesmus, and that word means the feeling like you have to have a bowel movement. Someone with pancreatitis with a serum calcium that's low, that's a low serum calcium, hand spasms. Crohn's disease, who had 3 loose stools this morning, someone with GERD with an antacid. Well, here we are back at our calcium problem. We have another calcium problem. And this is a low calcium with hand spasms. So we have another example of someone that has neuromuscular excitability. And this is immediately life-threatening. Like I was saying in the previous question, this could lead to seizures, to laryngospasm, to cardiac dysrhythmias. So I'm going to put a big arrow beside B, and let's see if anything can beat out B. Ulcerative colitis and the patient feeling like they have to have a bowel movement. Well, that's not a life-threatening sign and symptom. It's just a feature of the disease, and it's also just a normal feature of being a human being. So I'm going to cross out A. Someone with Crohn's disease who had 3 loose stools this morning. Well, one of the features of Crohn's disease is loose stools. It is diarrhea. It is all of those GI distress signs and symptoms. So that's not too crazy. And it also doesn't beat out seizures or airway. And D doesn't beat out seizures or airway. So I'm going to go with B as the correct answer. And just in case you're wondering about the connection between pancreatitis and serum calcium, in pancreatitis, so let's say there's the pancreas, not a very good one, but there's the pancreas. In pancreatitis, the pancreas starts releasing digestive enzymes, and the enzymes get into the fat tissue surrounding the pancreas. The enzymes actually get into the serum and start traveling around. So someone with pancreatitis, you'll see an elevated serum lipase. The lipase is coming from the pancreas into the serum and also into the fat surrounding. This lipase actually breaks down fat. That's what its job is. It's supposed to break down the fat that you eat, but if it leaches into the fatty tissue inside your body, it's going to break down that too. And that leads to fat necrosis. So little damaged pieces of fat. Well, those damaged pieces of fat actually join together with calcium, and they form something called calcium soaps. Saponification, that's what it's called. So I'm going to draw this together, the fat and the calcium. Now, this calcium is supposed to be floating around in the serum and doing the job it's supposed to do. But it got grabbed up by the fat. And again, it's called saponification. So now, instead of the calcium being free to do the job it's supposed to do, it's bound up together with the fat. And that means we have a low serum calcium. So that's how pancreatitis is related to serum calcium. So B is the correct answer. And now we're on a telemetry unit. So we have a patient so these are all going to be cardiac patients on a telemetry unit. Their heart rate and rhythm is constantly being watched with telemetry. Someone with heart failure, urine output 40 mils an hour for the past 2 hours. AFib, 84 beats a minute. Someone with chest discomfort who's sweaty and says this feels different. Someone waiting for discharge instructions. Well, I'm going to go ahead and cross out D right away, because this person's stable enough to be discharged and they're waiting for teaching. Well, teaching is the bottom of our priority list. Okay, let's go to A. Heart failure, urine output 40 mils an hour. Well, that urine output isn't super high, but our cutoff is 30 mils an hour. Greater than 30 mils an hour tells us the kidneys are being perfused. So this person's had 40 mils for the past 2 hours. So their kidneys are being perfused. It's definitely not a huge high urine output. So what's actually happening there is When you are in heart failure, the heart can't do its fundamental job, which is to propel blood forward. So you might have a decreased cardiac output. The kidneys take about 25% of your cardiac output. So the milliliters of blood that your heart ejects per minute, your kidneys take about 25% of that. So if you have a reduced cardiac output because you're in heart failure, you may have a reduced urine output. So that's what's happening here, but they're still perfusing their kidneys. So I'm going to cross that out. I'm going to cross out A. A client with AFib, heart rate is controlled at 84 beats a minute. So in AFib, I'll draw another heart here. And here's the left atrium and here's the left ventricle. What's supposed to happen is the left atrium actually gives a little kick into the left ventricle when it needs to empty. So most of the emptying from the left atrium to the left ventricle is passive. This valve opens and blood empties. But and different resources say different things. Somewhere between 20 to 30% of the volume of the left atrium is actually ejected with the atrial kick, with the atrial contraction, and it gets into the left ventricle. So there's a organized electrical response. Now, if you have AFib, you have all sorts of little contractions all over the atrium. And those are irregularly captured by the AV node, meaning that you are going to have a disorganized ventricular response. Your ventricle is going to be beating irregularly. Irregular. The pattern is all over the place. There's no pattern to it. So that's what's happening in AFib, and heart rates can get really high in AFib because of all this left atrium firing. It can just keep hitting this SA node and make the left ventricle beat really, really fast. And that's uncontrolled AFib, heart rate over 100. Well, this person has controlled AFib. Their heart rate is 84 beats a minute. So I don't think that takes higher priority than C. We have someone with chest pain who's sweaty and says this feels different from my usual angina. So it sounds like this person has stable angina. So they have some kind of a plaque on the inside of their coronary arteries. And of course, that makes this diameter tighter. So when you have an increased demand, you are going to get what's called stable angina. Chest pain with physical exertion that resolves with rest. That's what stable angina is. Well, if this plaque ruptures, so this plaque has ruptured, and now we get platelets gathering over here. We have a much narrower diameter. And so this is definitely going to feel to the person different from stable angina, because now we are in perhaps unstable angina territory. And the other hint that this is perhaps unstable angina is the sweatiness, the diaphoresis. So C is the client that we need to see first on the telemetry unit.